care. So everybody knows, okay, I'm not as everybody knows here, so let me just do the introduction. The gastrointestinal tract, that's the GIT tract. So it plays a vital function in digestion, in nutrient absorption, immune regulation, and overall health. The disorder that affect this GIT are like the leading cause for this, like among the most common reason for hospital visits. But the issue is that most healthcare professionals and patients, they confuse IBS, that is irritable bowel syndrome, and IBD, that's inflammatory bowel disease. So let me say it again: IBS is irritable bowel syndrome, when IBD is inflammatory bowel disease. From the inflammatory in IBD, you have to do with inflammations like that, um, the body acting against itself. So although this the thing is that these both conditions, they have similar symptoms. It comes with abdominal pain, comes with diarrhea, comes with constipation, bloating, and altered bowel habits. But they differ significantly in their cause, in their pathophysiology, in disease severity, in their treatment, nutritional management, and all. So if as a healthcare professional you confuse one for the other, it may delay diagnosis, it may worsen the disease progression, and then it can negatively affect the patient's quality of life. And our function as healthcare professional is to like improve patients' quality of life. So as pharmacists, we must understand the difference so that we can be able to recognize alarm symptoms, recommend appropriate therapy, counsel these patients effectively, and prevent drug interactions like that. So in order to understand this, I'm sorry. So in order to understand this disease well, we first need to understand how a healthy gut works. The function of an intestine, it has four major functions. Number one is digestion. All of us knows about that. Number two is nutrient absorption. Without the intestine doing this, one as we are just eating and passing out excrete without it extracting the nutrient in our body, to our body rather. Number three is water absorption, and number four is immune defense. The intestinal wall consists of four layers, from the innermost to the outermost. Let's leave that one. So now to IBS. I've said IBS is irritable bowel syndrome earlier. So this is a chronic functional gastrointestinal disorder. This is characterized by frequent, that's recurrent abdominal pain, and it is accompanied rather by altered bowel habits without any detectable structural damage or inflammation. That means that IBS, irritable, I'm going to be using IBS IBD. So you just know that IBS is irritable bowel syndrome, IBD is inflammatory bowel disease. So that means that IBS is like a functional problem, more like a an issue of the physiology. The structures still remain normal. If you are checking the intestine through colonoscopy, there is no issue with the structure. Those are the function as issue. That's the only thing that is there. So it's a functional disorder, when the other one, IBD, is a structural disorder. So it is recognized, that's IBS. I'm talking about IBS for now. We'll move to IBD later. IBS is recognized as disorder of the gut-brain interaction. So the bowel appears completely normal, as I said, during colonoscopy. It looks normal, but it is not but it is not behaving normally. It affects function, like I said earlier. That is affects the physiology, not the anatomy, not the structure. It's IBD that does that one. So epidemiology of IBS, it affects approximately 10 to 15% of adults worldwide. Females are at an higher risk times two of male, and it's commonly developed before the age of 50. And it is one of the leading cause of gastroenterology clinic visits, and it is frequently associated with with anxiety and depression. So you can see it from the slide. Two patients visit FMC or pharmacy complaining of abdominal pain, severe bloating, diarrhea, and altered bowel movements. At first glance, they seem to have the same clinical condition. It's just that you have to ask for more details. When I explain more, you're going to know how you can, because very, very easy for you to differentiate both of them. So when I explain more, you will know the differences. Don't worry, calm down. Pathophysiology of IBS. IBS results from several mechanisms acting together. So unlike IBD, there's no visible inflammation, there's no ulcer, there's no permanent damage. It's just that the communication between the brain, the nerves, the internal muscle, the immune system, the gut bacteria, they all got disrupted. The information is not flowing well. That's why IBS happened. So the number one cause, let's see if it's here. Yeah, a disorder of brain gut interaction. The number one cause is altered gut brain axis. So normally the brain and the gut, they communicate continuously through the vagus nerve. So the brain tell the gut that you should move, you should secrete enzymes, there's pain, and then the gut tell the brain back that I am full, I'm having pain, I'm inflamed, stuff like that, more like communication. In IBS, these signals they become exaggerated and you're not properly regulated. That's poorly regulated. So in normal person, I can eat beans now, and normally I have gas after eating beans. I might barely notice it, but an IBS person can start experiencing abdominal pain, bloating, more like the gut is sending a wrong signal to the brain, or it is making it like exaggerating it. Yeah, let me use that word. It's exaggerating it. So as I said, IBS patients they experience abdominal pain, the bloating, urgency, and discomfort because the brain is interpreting normal intestinal activities as painful, which assumes a normal person you are not going to feel anything. Number two cause is visceral hypersensitivity. So visceral refers to internal organs. Hypersensitivity means that it's increased sensitivity. So the nerves inside the intestine already become overly sensitive. What, as I said earlier, what somebody is feeling, normal person, you are having gas after eating, maybe after taking milk or after eating beans, but in someone that have IBS, it is tuned up, more like the volume is increased, so you are going to be feeling the pain more severely than a normal person. So that's why many IBS patients say they report that they have severe pain even during like normal colonoscopy. Then number three causes abnormal gut motility. So the muscle that is lining this intestine, they move abnormally. Sometimes they can move faster. So when they move faster, the water is not absorbed, and this leads to diarrhea, urgency, loose stool. And if there is slower contraction, more water are absorbed, which leads to constipation, hard stool, and bloating. And sometimes it can be like both. It's irregular. This hour rather, it is contracting. The next hour, it is like dilating too much, like that. It's okay, faster contraction and slower contraction as I add. So it's more like the person will be having diarrhea this today, tomorrow you're having constipation like that. And then got microbiota that if there's too much microbes, yeah, in the intestine, so can lead to this, can lead to something like this. So another, so now we have different type of IBS. I'm trying to see where it is in this slide. So let me just mention it. We have like four type of IBS. We have IBS-C. This means that constipation is predominantly. That means that there's slower contraction. The person is going to be having hard stool, is going to be feeling bloated and no constipation. There's IBS-D. This is diarrhea predominance. This is where the person is having more of diarrhea. This having faster contraction. Water is not being absorbed, so everything nutrients will not be absorbed. So as you are eating, you are going to be passing loose stool. You are going to have like frequency in you using toilets. And then we have IBS-M. This means that means diarrhea and constipation. And we have IBS-U. This one is unclassified. So now, what is IBD? IBD is inflammatory bowel disease. Sorry, this is IBD. So IBD is inflammatory bowel disease. This is a group of chronic immune-mediated inflammatory disorder. So this one they cause actual tissue injury, and it destroys the GI tract. So we have two example major form of this IBD. You have heard about it: Crohn's disease and ulcerative colitis. I'm coming. No, I just missed up. Yeah, Crohn's disease and ulcerative colitis. So the difference between these two, this Crohn's disease and ulcerative colitis. Anyhow, before I reach there, unlike IBS, in IBS, I said that it was not, it is a disorder of the function. This one is disorder of the structure. The structure are being inflamed. There's inflammation. It causes visible inflammation, ulceration, bleeding, and permanent intestinal damage. So if someone is having all these symptoms of abdominal pain, stooling, and then the person is having blood with it, that means that is IBD. If there's no blood, that's IBS, because IBS does not cause bleeding. So there's no blood present in stool. So difference between the Crohn's disease and the ulcerative colitis. Crohn's disease can affect any part of the GI tract from the mouth to the anus. So most times it's commonly the terminal ileum that it affects, and it is like a patchy inflammation, more like there's lesion here, there's no lesion here. Like I'm talking about, let's say that this GI tract is like a rope. So one part is inflamed, the other part is not inflamed, another part is inflamed. That's how Crohn's disease works. And this is like a foot thickness inflammation. That means that it enter into the GI tract, not just in the surface. Yes, it enter into it, and it can cause fistula. Fistula is like maybe there's and there's already like inside the intestine that is passing into other organs like that. Yeah. So yes, let me say tunnel between two structures. This is when the inflammation that erode the bowel wall. So the pipe is developed inside the intestine. It can pass into another organ. So that's why sometimes you have heard about this poop poop stool coming out of the vagina as example of fistula, erectovaginal fistula. So that's what causes it. And then another thing that can happen in Crohn's disease is that there's strictures. Strictures is when there's inflammation, the intestine becomes thinner, more like how will I put it though? It is contracting. Yes, let me put it that way. It is because they did like growth, it is already inflamed. So where food should pass is more narrow. That's just the explanation. And then there's malnutrition and abscesses too in Crohn's disease. So in ulcerative colitis, it is limited to the colon and rectum alone. It's not like from the mouth to the ileum, like mouth to anus, like Crohn's disease. Ulcerative, limited to the colon and rectum. It is a continuous lesion, not like it is skipping, like the former one that I talked about. And this one, it involves only the mucosa. It is not food thickness, as I mentioned earlier, and there's bloody diarrhea in both actually. And there's increased colorectal cancer risk. If you're having IBD, is it IBD? Yes, IBD. The lady has a risk of having colorectal cancer. Pathophysiology of IBD. So IBD develop when genetically, okay, let me say you are susceptible to it. You're an individual that is susceptible to IBD. So if you have like abnormal immune response to intestinal bacteria, this is the immune system, it will not mistake the normal gut bacteria for dangerous organism and to attack it. So it's like people that are affected, they are at the risk of it. They're like susceptible to it. So maybe like family history or that. So the process is that, okay, number one, the step one, genetic susceptible. So there are genes in our body that increase the risk of abnormal immune response. So then I say that, you now got exposed to maybe smoke, environmental trigger like smoking, infection. So this immune now activates. So they're trying to fight against those that you the trigger, environmental trigger that you're exposed to. So as they're fighting against it, it is more like it's becoming worse. Let me just say it like that. Then they start attacking themselves. That was just called like it's an immune disease that you're attacking yourself. So it just leads to continuous damage instead of healing properly. The intestine develop ulcers, fibrosis, bleeding. That's what causes the IBD. I've talked about Ebola. So the differences between IBS and IBD. So the clinical comparison matrix, nature of disease, IBS, IBD. So nature of this one is a functional disease, as I said earlier. It just affects the function. The structure is normal. In IBD, it is more of like a chronic structural damage. Structural in, as you can see, can you all see my screen, please? I didn't even ask. Sorry.
Yes, please. You can go on, fam.
Okay. So structural bowel damage. It is absent in IBS, but it's present in IBD. Systemic signs. There's no fever. There's no increase in white blood counts in IBS, but it's present in IBD. So in stool keratitis, there's utter consistency, either constipation or diarrhea. This one, there's highly frequent diarrhea with blood. So blood has to be present or mucus for you to identify that, oh, this is IBD. Malnutrition risk, it's extremely low, and this one is high. Colorectal cancer risk, there is no increased baseline risk. This one, there's increase in this. Mm, 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 mm. So IBS, when commonly presenting complaints, abdominal pain. So after you defecate in IBS, you feel relieved. There's excessive gas, there's irregular transit, but in IBD, you're still going to be feeling the pain, even after you use toilets. More like obviously is an inflammatory disease. So yeah, sorry, these are the symptoms profile in IBS: abdominal pain, excessive gas, irregular transit, symptoms trigger. So you have to like know the food, that some food triggers the symptoms. It wasn't after me, or when you're under emotional stress. More like when I talked about it being like it is associated with anxiety. You going to hospital every time and they're not like getting, because does not have any cause. Sometimes it just happen anyhow. So there's no way you not get depressed over it. And the more you think about it, more it's increase the risk of it happening, kind of. So the symptoms of IBD, there's blood in stool, nocturnal diarrhea. So patient wake up from sleep to go and poo. There's rapid weight loss. So yeah, when you are seeing weight loss, all this them stomach pain, you just this stomach pain, abdominal pain, diarrhea. It points to IBD too. There's extreme fatigue too. So, because IBD is a systemic immune mediated condition, other organ systems too are often targeted. So, there can be eye inflammation, skin lesion to bone to like osteoporosis. So, to diagnose IBS, before it can be like, oh, this person have IBS, it has to, there's this thing called Rome 4 criteria. So, it is a clinical diagnosis, like I said, but a patient has to be like having stomach abdominal pain for at least 1 day in a week in the last 3 months, and it has to be associated with two or more of this following. Pain has to be worsened or relieved by bowel movement. It has to like be There has to be like frequency, maybe increase in frequency of stool. There's change in stool frequency, and then the stool transform from hard pellets. There's a change in the stool too. It can be either if it's constipation, is going to be like hard stool, and if it's diarrhea, is going to be like a watery stool. So that's how you are sure that this person have IBS. So these criteria have to be met. I'm sorry. So for IBD, lab investigation to differentiate between IBD and IBS. So if there is, you will check for food blood counts, and there is like anemia. You know the person is already losing blood through through a channel, so you can suspect IBD. If there's inflammatory marker like elevation in CRP, in ESR, you know that okay, it is IBD. Then another imaging too can can visualize what is wrong in the intestine. So now we can know that okay, there's the inflammation through imaging like CT, MRI scan, and all. So these are the red flag in IBD. There should be rectal bleeding, weight loss, nocturnal sign like waking up from sleep. I've talked about that one. And then the onset. I mentioned about IBS that the onset is less than, it happens mostly in when you're less than 50 years. This one happens like higher than 50 years. So now the pharmacotherapy of IBS subtype. If you are treating for IBS, you have to like differentiate. I mentioned them having like different types. So you have to treat based on the types that are there. You can't be just giving anything. Okay, now I mentioned about IBS constipation, IBS diarrhea, IBS missed, IBS undiagnosed. So for IBS constipation, you're trying to treat according to symptoms. That's basically how you treat irritable bowel syndrome. You treat the symptoms because you don't even know the origin. So there's no way you can tackle the origin. So for constipation, it gives soluble fiber in order to increase the stool softness. You give this, you give lubiprostone to promote intestinal fluid secretion too. I give linaclotide here to reduce visceral hypersensitivity. And for diarrhea, you give loperamide for to reduce frequency, to slow motility and increase fluid absorption. And the other, and then for the pain, for global pain control, you give low dose amitriptyline, which this one helps to like relieve abdominal pain of it. So, and then managing of the missed IBS missed, this is like one of the most challenging subtype because you don't even know, since patients alternate between constipation and diarrhea. So the best thing is to first educate the patient for everything. The IPS, educate patient education is necessary and reassurance that okay, what is happening to them is not something out of the extraordinary. They should do regular exercise and stress reduction too. Adequate hydration, and then I'm going to get to the low food map diet. So let's do, yeah, they can do that one too, but I'm going to explain that one later. The low food map diet rather. So this pharmacotherapy of IBD, you give steroids for the acute flare induction. You give this immunoid is for the maintenance actually. Wait, I'm coming. Yeah, management of IBD. So for if the disease is still mid, give this amino salicylic acid, that's the 5-ASA drugs. And if it's a moderate disease, that means is already progressing. You give corticosteroids like prednisolone, budesonide. And for the maintenance, that you give the immunoloid like the azathioprine and the methotrexate. So example of the amino salicylic acid drugs are mesalamine, sulfasalazine. They help to reduce inflammation. They act on the intestinal. Since our goal is to reduce inflammation, that's just basically just give drugs that reduce inflammation. But then when you are giving sulfasalazine, you have to like be giving 1 milligram of folic acid daily because this drug they block the direct absorption of folic acid. Azathioprine, that's the monoloid too. This one they help to, so they work by suppressing lymphocyte proliferation. So it's when the patient has recovered remission. So it's just for the maintenance of remission. It's not for the rapid control of. It's not for the control of the flare actually. It's just to maintain their maintenance just like that. So now to the nutritional control. If a patient is diagnosed with IBS, that's irritable bowel syndrome, you have to avoid food that have high FODMA. So FODMA is um fermentable. I thought it should be here. Okay, fermentable oligosaccharide, fermentable disaccharide, monosaccharide, and polyols. That's sugar alcohol. So I've listed example of high FODMAP food. These are triggers to avoid. These are for IBS actually. This is like for IBS, but I feel like they can still apply to IBD. So the person has to avoid food with garlic because it can produce gas too, and it is slowly digested. Yes. So you have to give food that are easily digested, like the load FOMAP. So these are load FOMAP, they are short chain carbohydrates. They are that can easily be absorbed by the intestine. As I said, high FOMAT food, they are poorly absorbed in the small intestine, and they are rapidly fermented by gut bacteria. So it leads to gas, bloating, abdominal pain, and this can worsen the symptoms of IBS. So how to do this low FOMAP diet? So the phase one is elimination. You first avoid all high FOMAP food for 2 to 6 weeks. So you want to determine if the symptoms will improve. Then phase two, you now start introducing the carbohydrate food group over 3 days. You want to see which one exactly is going to trigger these symptoms. Then The phase 3 is you crafting a sustainable long-term diet that restricts only identify trigger food. So I've listed the example of I food map food that you can afford, that you can avoid, and the safe alternative that you can eat. So other common IBS triggers are fatty or fried food. So someone with IBS should avoid all these fatty food, spicy meals, carbonated drinks, alcohol, artificial sweetener like sorbitol, mannitol. I think it should be under polyps too. So dietary recommendation by subtype. For IB, for those that have constipation predominant, you have to increase the soluble fiber. I think that one was mentioned. I've mentioned that one too earlier. That you give psyllium oats. You drink 2 to 3 liter water daily, regular physical exercise, and avoid insoluble fibers like wheat bran because it's going to worsen your bloating. And IBSD, you limit caffeine, avoid alcohol, reduce high fat meal, restrict lactose if you are lactose intolerant, avoid spicy food, choose soluble fiber over insoluble. I eat smaller frequent meals so that so that they can digest on time. So flare versus remission. So this flare goal is to minimize mechanical friction or on ulcerated bowel mucosa. You have to avoid raw veggies, avoid nuts, seeds, skin or peel. You eat mashed potato, this one they get absorbed easily. So not like you are going to like be stressing the intestine and all. Eat white rice, lean chicken, liquid supplements. And when you are in remission, anti-inflammatory, the goal is to nourish the microbes with high diversity nutrients like Mediterranean eating pattern, high in cold, pressed olive oil, and that's so. Let me come, please. So the meaning of Mediterranean eating pattern is more like you are flavoring fruits and fibers over processed meals. So that's just basically the explanation of it. It's more of of soluble of Jesus of digestible fibers and fruits over all this processed food, canned food and all. So when you are treating IBD, there is possibility of having some deficiency like iron deficiency, vitamin, calcium. So the cause is that okay, you are obviously bleeding from intestinal ulcer, so you can lose blood from it and iron. So it can lead to microcytic anemia, fatigue. So this one you can treat with IV or oral iron. For vitamin B12, there's inflammation or recession. That's the Crohn's disease. So it can lead to deficiency in vitamin B12. And the clinical presentation is megaloblastic anemia, and then the management is supporting with regular injection of vitamin B12. So when you are treating someone for IBD, you have to watch out for all these nutrients that can get deficient. So more like put them on a frequent test. They have to be monitoring, frequent monitoring rather, so as to see if it is becoming deficient and then do the needful if that is happening. Mm, mm. So there's another thing of exclusive intra nutrition. So ENN, this is like if the person can maybe it's a case where the person can eat again. So it involves meeting 100% of nutritional need through liquid formulation for 6 to 8 weeks. So this will allow the intestine to heal. If it's like an inflamed intestine, so it's going to get absorbed easily. I can absorb all the nutrients that you need easily. So for mucosal healing, it induces direct mucosal healing rates compared to systemic steroid. It's ideal for pediatrics, for children, and helps to rest and reset the gut lining. So, as a pharmacist, all we should do is we should check the dose of this steroid, check for if there's drug interaction, check that patient that are on sulfasalazine, they are taking their folic acid frequently, and their LFT, they should be all the tests that you should be doing, food block and white block, and they should be doing it every time to to know that okay, this is not getting worse. And then patient down immodulators, they should do their LFT and CBC from here too. And then you should reassure patient that their pain is real. So it's not like they are they're imagining it, or there are people too that are feeling that are in their shock kind of, and they should keep a detailed food and symptoms diary so that they will know that okay, when they take a particular food that they react to, they will know how to like avoid that particular food. And then we should advise them on the risk of self-medication with NSAIDs and all. And then we should optimize medication rules and help them to monitor adherence too. They cannot just stop their drug anyhow. And when they're on corticosteroids, so we should advise them on the side effects and what they should watch out for. So that's all, ma.
Thank you very
Thank
much, Fam Adiola, for that wonderful presentation, detailed, and then for your light-hearted approach to the presentation. It felt like I was in front of a colleague, in school having good discussions. The simple way that you explained it. Thank you very, very much.
yes,
So I would
ma'am.
like to ask if we have any questions,
Mhm.
people can raise your hands, or you can put it in the chat box if you prefer that. Does anyone have any questions?
Not only questions, maybe comments, maybe correction, maybe addition. Anybody that can throw more light to.
Yes, yes, please. Any comments, additions, suggestions, corrections, commendations, anything?
I think some people are raising up their hand.
Check the participants. I can see 2 electronic hands.
Pam Bolariwa, please, what's your question, sir?
Thank you for the presentation, Farm. During the course of your presentation, I think that should be that should be under slide 19 or 20. So when
Okay.
you were talking about the management of IBS and IBD,
Okay,
you
sir.
made mention of amitriptyline being used to reduce pain. So I would like to know the rationale behind that, or is it off-label use of amitriptyline for management of pain in IBS and IBD patients? Thank you.
No, okay. I don't know if I made mention of it that is used at low dose. At low dose at night, it can serve as a pain relief. That's like around 10 milligrams, sha. So it's at higher dose that is used as antidepressant. So when you keep it at a lower dose, it can be used for the IBS pain. Or is that not what you asked, sir? Yes, it is off
Yes.
label. Enough, yes, it is off label in most places, but they still use it.
Okay. Thank you.
Yes, sir. Doctor, from Moffat, please your question. From Moffat. Okay. Dr. Fumilayo
Thank you very
rather.
much for.
Sorry.
Hey, can you hear me?
Yeah, I can hear you. I can hear you.
Okay, thank you very much for the presentation. It was a wonderful one. Well, I just wish that we had the slides with us. I hope it will be sent to us after this, because sometimes you were rather fast, and I wasn't able to follow all through. But I have some questions to ask. Thank you. The
Okay.
presentation was very wonderful. There was a point I heard you mention that if someone is susceptible to IBS, so what makes a person
Wait,
susceptible?
calm
Is
down.
it genetic?
You said if someone is
Can you hear me?
susceptible to IBS, I can hear you. Please come again.
Yes, yes. If someone is
IBS,
made
Abby.
mention of someone, yes, yes.
Okay.
So what makes someone susceptible? Is it a natural thing? Is it genetic, or are there lifestyle factors that makes someone susceptible to this
I think
condition?
when I mentioned susceptible was in IBD, that it might be like family history. That IBS, it does not have a cause. So it's more like it just happened. There is no like a particular cause. Let me put it like that for IBS. It's kind of just like your body not passing information right. There is like a disconnect between your brain and your guts. That's for the IBS. So it's the IBD that was saying that you can be susceptible to it. Then when you are exposed to environmental trigger, that it can lead to your immune system trying to find those triggers, and then in that process they end up fighting your body. That was where I mentioned triggers.
All right, thank you very much. And
Mm,
another question quickly. As probably as a pharmacist working in a community setting or in a setting where there's no access to diagnosis, clinical
okay.
diagnostic tests. So
Okay.
what is the most distinctive feature that can help you like quickly and easily distinguish between IBS and IBD so that you won't
It's just
treat
the blood.
wrongly?
The blood in stool. IBS does not have blood in stool. IBD will surely have blood in stool or mucus. And then this waking up at night to stool, nocturnal diarrhea, it happens too. But the first thing you should look out for is that blood in stool. A person complaining of having blood in stool, and I mentioned that okay, abdominal pain, that has to be like once a week, at least once a week, with change in frequency of stooling for over 3 months. Then IBS, this is the normal case. IBD, the person is having that, okay, I'm having blood. Blood is in my stool. Another case is IBD. There's blood related with it. Do you understand me?
All right. Yes. All right. Thank you very much.
You're welcome. Um, Dr. Fumilayo.
Thank you very, thank you very much. I really want to commend and appreciate the presenter. I like her confidence, the way she has spoken, and it's an educative lecture that she has been able to present to us. I just
Okay.
want to request that she will keep it up.
Oh, thank you so much, ma. I really appreciate it, ma.
Okay.
Please, does anybody still have question or comments, or I can do better? My mom, no comments.
We have dear moderator on the call. I don't know whether she has problem with her network. Famojo, are you still there?
Yes, ma'am. I'm here.
Okay.
Yes,
So if
there's
there
just
are
some
no
noise here.
presenters and people that want to ask questions, you can ask our chairman. I think she's on the call too, Dr. Morin, maybe for closing remark or something like that.
Okay, thank you, ma'am. I'm trying to. Oh yes, I can see. Thank you very much, Dr. Morin for joining us. Please, would like you to just make some comments as we come to a close.
Good evening, dear colleague.
Good
I
evening,
Good
ma'am.
evening.
Yeah. I want to appreciate our dear, irrespectable Pharmacy mom, always organizing a nutrition for health specialty of CFA. Thank you so much for wonderful work you're doing in CFA.
Thank you, ma'am.
Yeah, our dear presenter, Dora Gifts, thank you so much for your confidence in
You're
making out
welcome.
tonight's presentation. Keep it up.
Yes, ma'am.
And
Thank you.
the moderator from Ojo, thank you so much. I want to especially thank our dear mommy, Dr. Fumilayo. Mom, you always with us. God bless you. Seeing you always in our programs gives me great motivation. Thank you so much. You're retired, but you're not tired. God bless you, man. Okay, on behalf of CPANMEC and all the members, I want to appreciate everyone who joined us in tonight's clinical meeting. Personally, I learned a lot. Frankly speaking, I didn't even know what is the difference between IBS and IBD, but I've learned that today. Even today in the morning, I had a patient, just a friend, okay, complaining, you know, diarrhea at night. It becomes so weak. She will take this, I was asking her, do you have ulcer? She said I've been taking ulcer drug, but man, I now have to know that it may be IBS. So tomorrow I will really educate and counsel her better. So it's good that we always join different activities because we must go home with one or two information that will help our person. So thank you so much. See you once again. Enjoy your night. God bless.
Thank you very much, ma'am. I would like to call on Farm Abdulhamed Shoyebo to just give us a short closing prayer so that we can call it a day. Farm Abdulhamed Shoyebo. Are you on the call, sir? Okay, what about Farm Bolarinwa read one? Pharmacist Bolarinwa read one.
Oh, yes, ma, I'm here.
Oh, please, can you give us a closing prayer, sir?
All right. We thank Almighty God for making this presentation a success. We also we also thank him for making us for making us comprehend what has been presented. So pray to God that He makes us to make use of it and in our various practice centers. We ask Him to spare our life till next presentation, keep us alive in sound health and mind. Thank you all. Have a wonderful night.
Amen. Thank you very much to everyone. Have a wonderful night rest till we meet again at the 7th edition. Thank you so much, everyone. Good night.
Yeah, good night. Thank you so much, Famoju. Thank
Yes,
you,
ma'am.
our Fam Gift, and thank you all our participants. Good night.
You're welcome, ma. Good night, ma'am.
Good night, everybody.
Good night. Good night. Good night, Famoma. Good night, Mrs. Oluwatimileyin. Good night, everybody. And gift well done.